started a minute early, if that's okay with everybody.
Recording in progress.
Join me for the flag salute. I pledge
Allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you.
We have one special request. Dennis, would you like to come up? Just before we get started here, Dennis asked for just a couple of minutes.
Just a couple of minutes.
Okay, and identify yourself, and then you get to talk into the mic.
Okay. I'm Dennis Simontaki. I own the lot immediately on the south side of the helipad. And I'm sorry to take your time. I had no other option. I'll make this as brief as possible. I called the CEO 4 times to talk to him. I left messages on his phone twice. I left a message with his administrative assistant, and I left a message with Tina. I think she's the HR person. And I left very polite messages. Didn't cuss, didn't yell. Asked him, I said, if you could call me back, I'd appreciate it. If I'm not here, please let me know when a good time to contact you is. This was weeks ago, never got a call. Well, you know, I was brought up to have respect for people and be courteous to people. And that's not the way to treat fellow community members and neighbors. That's all I've got to say. Finally, I just want to say finally, Justin Westcott gave me a call. He somehow got a message, he gave me a call. That's all I have to say. Thank you for letting me speak.
You bet, thank you.
I'll address that. I apologize before you head out. Before you leave, let me go get a card for you. It has my cell phone number on it. You can call me anytime. It's a much better way to get a hold of me. Or you can always stop into my office as well. So, thank you.
Okay.
Yep.
Okay, thank you. Next item on the agenda is approval of the consent agenda. Has everybody had a chance to take a look at the documents?
I so move we accept the consent agenda.
I will second.
Been moved and seconded to approve the consent agenda as presented. All those in favor?
Aye.
Okay, passes unanimously. Okay, Kelly. You're up, Kelly. You've got the floor for the next 2 hours.
Oh boy, don't give me that kind of permission. I'm just kidding. Anyway, thank you guys so much for listening to me this evening. We're going to do a couple different things in the financial report. Due to the July 1st deadline, which is the end of our fiscal year, start of the new one, as well as the county deadline, tonight we're going to walk through the resolution and the budget process and get the budget final approval, as well as the LB 50, which is the tax certification. I did meet with Mr. Knowles today to go over the tax certification, and we are going to go ahead and approve that and file that so it is filed timely. It is due by July 1st, and it is my mission to get that in on time this year, unlike in years past. The other things that I'm also going to be working through with you guys tonight is the financial statements. It will be a little bit more of a meatier conversation tonight. I had a deep dive conversation with the Finance Committee earlier this week, but I want to be very transparent about everything we've continued to work through and discover, since so much has changed since our last budget hearing. And I think it's important for all of us to be on the same page. So what I ask is, as I start sharing the screen and walking us through everything, that you guys feel free to pause me or ask questions. The goal is to get transparency across the board on this. I do want to talk about the process for budget first, just because of the way of timing everything with Landon's arrival and my arrival, and how long a budget normally takes to prepare, and what also transpired prior to us being here. Tonight's budget is going to be what we call an interim or an intermediary type budget. I'm going to have you still approve it. We have a resolution to be signed. This will check the compliance requirements for the facility. As I mentioned in our last budget hearing, the budget that was prepared by the outsourced team was missing lots of pieces of the puzzle and the full story of Lake Health District. I think it's really, really important that we have transparency. You don't get into the day's cash on hand concerns that the organization has faced in the last couple of years by having positive financial statements. And unfortunately, as a board of directors, you've been shared information that was positive in nature when in all reality, the facility was facing losses that have not been reported accurately. As a result, that inaccurate information was then used to prepare a budget, which was misleading. You have 3 or 4 years of losses as an organization, and then to turn around and make that into a $2 million positive bottom line was a mystery to me. And after diving into it and working through the budgetary process initially, we've proven that it is not accurate. So tonight what I'm going to do is walk you through where I have made changes from our last iteration of the budget and ask that you guys as a board approve the interim. Then from there, we're going to go into a 60-day deep dive with each individual department on their financial health, the organization's management, as well as the goals and objectives of both the board and the CEO and Landon. And we're going to put together a supplemental budget. We'll come back to you in 60 days for a formal approval of an amended budget to include those updated changes at the departmental level. There is so much opportunity to make more money for the organization, and I can't emphasize it enough. But I also do not ever want to mislead a board or the public or the department leaders about where we currently stand financially. And so that's where tonight is going to come from, is a realistic picture of where we're at and what we're facing, and then how we're going to move forward as an organization. Because I do believe a lot of the information that's been shared in the past has been misleading, but we're going to get it accurate, and we're working through those phases every single day. So the first thing I'm going to share with you tonight is the actual board, the budget presentation itself, and again talking with you about how the changes have happened related to the budget itself. So give me just a second, I'm going to share my screen. Make sure I do this correctly. Forgive my timing here. Can everybody see my screen okay?
Yes.
Thank you. All right, so as we're calling it the interim budget, this is what the resolution is going to be proposed based off of. So as you're well aware, we have timelines. We had the May 15th hearing and conversation that was reviewed by the advisory committee. From there, we started working through the modified budget. I outlined some key concerns in that meeting, specifically around revenue contractual adjustments, as well as some of the expense line items that, I only literally had like a couple hours to review the budget before it was presented to you guys as the board, since I was new to the process at that time. And so as a result, we went ahead and made some of those changes. The budget assumptions that we changed right out of the gate specifically are related to background information for the organization. So for an example, we updated things like depreciation. We've talked about grant dollars, some specific expenses and wages and benefits for pharmacy, radiology, rehab, public health, and supply chain, as well as adjusted things like contractual adjustment. And I'm going to walk through each of those individually. I know I rattled them off very quickly. But what this means is we revised or changed the bottom line by well over $2 million, like multiple millions of dollars. Those changes alone were $2 million. If you add the contractual adjustments to it, we swung the budget from being a positive bottom line to a negative bottom line, because it truly matches the financial statements that you later are going to see from me this evening based off of collections that are happening from a payer perspective, so how we're getting paid. And then also, the budget originally presented to this board did not include the union updates for wage increases. It did not include the proper benefit calculation for updated benefit costs. It did not include changes in regard to supply inflationary costs. And then it also, it's missing lots of pieces of the puzzle. There's a lot more to still unpack. As I've mentioned to a lot of the department leaders in our organization, the department heads' ideas and or requests in the budget were not really put in either or factored in appropriately. And so we literally are bringing it down to a scale to meet requirements for the sake of timelines today to give you a more realistic view. The goal of this budget, the way we approach budgets going forward, is based off of true modeling. So we take your actual patients seen and statistics, as well as FTEs to determine where does the money come from, how much we make per patient, and how much it costs to do that work. The budget approach done in the past, historically, was stuff that I've seen a long, long time ago in my history, and it was taking prior year behavior and amortizing it to include the current year and doing some small percentage adjustments to get the bottom line to where we wanted it to be. And that's not effective because you're missing multiple pieces of the pie. The first thing that budget did, in terms of the assumptions, is it factored in like long-term care still being a part of the plan, and that's gone. I mean, we know it closed this past year, and so we don't want to put that in the budget this next year as if it's still around and behaving the same way. The other thing is like I said, it wasn't accounting for the true statistics and how that impacts actual patient revenue. So you'll see some of the main things that we've changed are the wages and benefits. Originally, there was a 5% across the board increase, but we know that specifically the nursing, so there was a nursing salary increase from the nursing union that was actually 9.5%, not 5%. So we were already off basis from the 5% increase because we didn't factor in what was approved as part of that union contract. The other thing that wasn't factored in is a discussion around contract labor. We specifically outlined one in the radiology department because there's been a transition of a staff member coming for next year, but it wasn't factoring in that contract labor was a replacement of an actual team member and how that impacts the wages specifically. In addition to that, there was also some FTE differences in regards to administration. You brought on Landon, you have myself coming on board, and other factors that were included in the administrative component that weren't properly factored into the budget. So we started making those iterations and changes. We know more are coming because, for an example, I'm working through the process of truly setting up our finance team that includes everything from revenue cycle to the accounting team to grants, etc. And so those types of things will impact the future supplemental budget that I'm referring to earlier. The other thing that also was really critical was the original budget presented to you had nothing to do with patient volumes. And we know patient behavior has drastically shifted for our organization. If you look at the number of patients that visit our organization comparative to prior years, there's definitely been a behavior change. And this is where Landon and I wanted to use this budget and forecasting as a tool to determine leakage based off the zip code and location, determine what departments were not being fully utilized because maybe the public was unaware of those services, etc. And so we have now moved to a more volume-based model to actually project out true patient volumes by department. The next big thing, which will also be very reflective in the financial statements when we get to those for the current year-to-date projections, is the contractual adjustments. These things are, for example, if we charge, I'm just going to use a safe number, but if we charge $200 for a patient to be seen for a specific procedure, that doesn't mean they actually get paid $200. It depends on the payer. So United Health might pay one fee, Blue Cross will pay a different, Medicare a different, Medicaid a different. Well, the budget doesn't factor in the behavior of the payers. Our financials didn't either. That's why our bottom line will reflect a change in that as well. So if you look at the budget that was presented, we only had $15.9 million, only, jokingly stating, of contractual adjustments, but really it should have been closer to $19.8 million in contractual. So we literally reduced revenue by $3.8 million to correctly state how the payers are actually paying our facility. Is this changeable and improvable? Heck yes. And I would be remiss if I led this board to believe that it could be changed overnight and it's not going to take 6 to 8 months to actually move traction on this. And so that is why we had to increase revenue reductions in order to properly reflect the bottom line of our organization. We also then factored in grants revenue. The original difference between the bottom line and trying to get it to be presented better was that the prior individuals that did the budget projections factored in a gross increase in grants. There's not that many grants to go after. We're talking like 2.5 times what was done this year. Grants management is very expensive, and also there was no expenses factored against it. So we realistically restated grants based off of an increase, but not the drastic increase that you had seen in your original presented budget, because that's not realistic. especially because they put no offsetting expenses against those grants. Grants are designed to further programs and have expenses offset them, but the way it was presented in the budget was assuming that we just get free money, and that's not how grant programs work. We also know that supplies they factored in a 3% inflationary increase. We went ahead and kept that for now. We know in the supplemental budget process we'll be evaluating by department, because we know, and I already kind of clicked on this department and it's not an intent whatsoever, but I'm using it as an example. Pharmacy is going to be very different from inflationary costs comparative to medical supplies, comparative to labs, comparative to others. And so we want to be very specific and very granular. Otherwise, again, we're misleading department leaders, we're misleading you guys as the board, as well as the community on true productivity. The other thing that was really interesting, and this is where I know we're having lots of discussions at the departmental level and the organization level, is capital expenditures. Capital doesn't show up as part of the profit and loss. It's a cash flow item, but it shows up on the balance sheet. We get to pick up depreciation on the cost report and get incentivized for it, but you have to have cash to do those types of things. Originally, the original forecast had included $1.1 million in capital. They didn't say what departments got their capital honored or not, and only $100,000 in depreciation. When you're in a cash position like ourselves, I couldn't, from a fiduciary lens, put that kind of capital on our budget at this time. Does that mean that it's off the table? Heck no. I've already shared this with the department leaders. What we're going to have to do is really strategize when we prepare the supplemental budget around how do we get the capital improvements that have to happen in our facility to make equipment up to par, the building up to par happen when we know from an operational lens there's not cash right now to do so. There are alternatives. This is where grant funding and alternative funding comes into play. This is where we start talking about how does each department increase reimbursement, etc. So we actually removed the capital component that was added by blanket by the original preparer of the budget, in knowing that we're going to be modifying and changing this as we do our supplemental budget process. So all in all, what this means for you guys as an organization, the 2025 budget is going to show a $1,974,809 loss. This is drastically different from the May 15th presentation of this budget. It's super important to understand. This does not make our equity go negative. I want to be very clear about that. Do I think we have room to beat this number? Heck yeah. But I would be very, very misleading to you guys to say that we're going to make a heck of a lot more money, like a $2 million positive bottom line, when we're in the current condition we're in, and July 1st is rapidly around the corner, and there's a lot of work to be done to be able to improve it. So my goal is, again, to share with you a more conservative approach to the actual budget itself, and walk you through those changes that we made to the budget that you already had seen, so that way we can have your approval for the budget as it's written, knowing that 60 days from now I'm going to come back to you guys in the board meeting and give you an amendment based off of the changes we're going to make by each individual department. If you want to get into more of the weeds, because I also know that we went through this with the finance committee and others, there is statistical data that we've actually used to back some of the current findings. But as I've mentioned, this is a high-level view of what we know is to come after we do the supplemental budget process. So I'm going to pause for a second and see if there's any questions on this before I talk about the tax mill levy part of the budget process.
Questions? Oh my gosh, that was a lot of information.
Yes, absolutely.
It is. I'm sorry. I don't know how to not fire hose it, so I apologize.
I don't have a question, but I do want to make a comment, and that is, it might sound horrible, but I'm thrilled at what was just presented to us. If that's where truth lies, well, so be it. And I'm excited to have the confidence that we're finding where truth lies, and that we have the numbers and the budget that's real, and I have confidence in that. So thank you for that.
I appreciate that. It's really hard to deliver that kind of news, and I appreciate hearing that. I know I've been talking one-on-one with different department managers, because I know they've been misled too, and that's not fair to anybody. But I also know if we know what true point A is, we can make change. And that's what we need to do. We need to be very transparent, work through what needs to happen, and make the changes. And it's there. I'm very confident in it. We can't do it in the cloud of a lie. It's that simple.
So the $58 million budget for 2025 is a 5% increase over the 24 revenue. Is that right? It's a 5% increase that will be generated through speculative increased patients or something, I guess.
There's going to be a lot of change to that number. We're going to do it by department. For now, the way I'm presenting it to you guys is a holistic 5%. We have a lot of departments that are losing patient volume just because we have them strategically built out, like provider recruitment, patient volume increase. Like we've had some leakage just due to like transitions that have happened in leadership. We get to build the trust back in our community and the services that we offer, and Lambden's already making steps to do that properly. Do we have a long way to go? Yes, but I think some departments are going to have gross increases compared to others that are going to have a little bit more flat-based. The other area of opportunity to add to that is our contracts with payers have not been touched in a very long period of time. So having the hard conversations with the Blue Crosses of the world, the Uniteds of the world, as much as I hate saying it, Humanas of the world, we get to go up to toe-to-toe with them and say, hey, you're not paying us according to contract. But the thing is, those payers bank on smaller facilities like ourselves to not fight them. And the more transparency we bring to revenue cycle, the easier it will be to say, you're not even paying us according to our legal agreement, and we can actually have leverage to walk away, which will force them to negotiate. And that is my mission, is to get to that level of ability. And it's there. I've seen it. I've done it with facilities in the past. And so that 5% is a conservative approach. I think there's a lot more room than that.
Okay.
Thank you.
Yep, like you say, drinking through a fire hose. I appreciate it.
All right, so before we move on from budget, I have to mention, so in your packet, you'll see what's called an LV50. It's towards the back. Resolution and LV50. The resolution is the language of where these expenses come from. In governmental accounting, we use words that make no logical sense, and I'm sorry for saying it that way, but that's how it is. We use this thing called fund accounting. But in special districts, we really only have one fund. But we call it different things like capital, personnel, materials, etc. So the resolution itself is literally taking everything I just shared with you in that PowerPoint and putting the numbers in categories to state where we're going to categorize those expenses coming from. And then the other piece is our mill and certification with the county. I actually met with Mr. Knowles earlier today to walk through that process. And so we do get a mill, and he gave me the dollar amounts and the mills on that LB50 form. And so tonight, I ask that this board approve the resolution prepared in the packet, which encompasses the LB50. That resolution will be filed with the state as well as the county by the July 1st deadline, which will be a first in a long time for us. I'm super excited about. And then from there, we'll amend it at a later date when we have the supplemental budget approved.
Okay.
Kelly, this is Gerald Stewart. What was our rate per thousand last year? I noticed this is 203.11 this year. Do you have that number?
It's the same actual rate per thousand, but it's
Okay.
a 1% decrease in collections.
Gotcha. Okay, thank you.
Yes. Good question, because I asked that question earlier. It's the only reason I know.
Any other questions?
I'll make a motion that we approve the,
Resolution.
okay, thank you.
Resolution 2025-1.
There you go.
Second.
Okay. It's been moved and seconded to adopt the resolution 2025-1 for appropriating the budget, making appropriations, categorizing, and levying taxes. All those in favor?
Aye.
Passes unanimously. Thank you, Kelly.
Great, so if you guys don't mind, I need the secretary, treasurer, and president to sign on those dotted lines on the original that Kyle has, so that way I can file that respectively but after the end of this meeting.
Okay.
The next presentation, I will move through this one faster, just because I know I want to be respectful of time, but I also, again, at the sake of transparency, want to go through the financial statements, because I did drastically change those for the organization this month as well. It's going to share the same narrative as the budget. My main focus, as I've mentioned before, and will continue to mention probably for the next couple of months until y'all are sick of hearing of it, is the revenue cycle. Right now, my goal is to get every department leader credit for the work that they're doing, and so you'll see that I've adjusted our financial statements around the revenue cycle the most this month. The high-level overview that I do want to go through is specifically around the profit and loss statement. So as I've mentioned before, we're not getting paid by payers and for the work that we're doing. On average, anywhere between 68 and 72% of the work we're doing is not getting paid. And I'm pausing to let that sink in because that's a lot to be written off. And as I've mentioned with the finance committee, we want to see that we are collecting closer to the 60% mark, not the opposite. And it's swung, the pendulum swung. In order to properly correct this in the financial statements, I have to remove or reduce our accounts receivable to what's truly collectible. And our gross accounts receivable is reporting about 15 million with a net collections of about 9 million. We're actually truly net collecting about 5.8 million, which means I have to remove the AR that's bad on the books and give you a true picture of what's the future of collectability for the claims that are currently sitting out there. As a result, I booked a $1.4 million additional adjustment on top of the 1.5 from February to reduce our bottom line to properly reflect what has come in the door for our organization. That swung our bottom line to a $3 million loss. And it's really important to understand this because next month we're going to continue to see these changes and adjustments until the AR gets fully cleaned up. I don't anticipate another large hit, but there's going to be a couple not great feelings for a while in this particular area until I get accounts receivable fully resolved. A lot of it came down to like the long-term care facility was not properly closed down, and so the aging was still on the books. We have to remove those claims. You can't bill for them anymore. We had claims sitting out there from 482 days. No payer pays those anymore. We need to remove those off of the books. So I've been working with QBSS on removing all of what I call dead wood off of our books and having a true picture of what we can, as an organization, collect. We've also been working through the cash flow and payment process of that collections to be able to clearly articulate that. It shouldn't really surprise anybody though, because you can't have 6 days cash on hand or 10 days cash on hand or be playing within under 20 over the last couple of year and a half and have a positive bottom line. The narratives don't match. And so this gives us a way better picture of true narrative of our organization. I project by end of the year, by the time we close May and June, we're going to be close to that $3 million loss mark for the year, which is why the budget had to swing from a $2 million positive bottom line down to the loss of the $1.9 million. Because it's not realistic to be able to improve that much that quick. That's a $5 million improvement. If we do that, Landon and I are like going to throw a party like nobody's business. It's insane. But it's just not realistic. This also means that we need to go into, like I said, the granular level of every department and get them all armed with the right information. I got the opportunity to meet with all the department leaders earlier today and talk about what data they've been given and how it's going to look different. Because again, things have been presented in a manner that is misleading. Is it incorrect? Not necessarily. It's just missing parts of the puzzle, which can cause people to think that they have more money than they do. So the rest of the packet is available, and I know last time I went through this at way granular level of detail, and it probably bored some people to tears. But the rest of it, like the behavior as far as wages and expenses, is not different. Where most of the change, or all of the change for that matter, happened is in this revenue deduction line item. But I can confidently tell you it's a lot more accurate picture of where we stand. And you can bet your bottom dollar, since it is the biggest impact of our organization, that is where my time and effort is being spent. The rest of this is, like I said, is pretty par comparative to what I shared with you all last week. We're just not getting people paid or credit where credit is due, and that is my mission right now. Every department leader has the best interest of this organization at heart. They're just not getting paid for it. So instead of boring you and walking you through the full PowerPoint, I'm going to stop sharing unless you all want me to go into greater detail.
I just have a comment. This is John Shine. We went through a lot of this in a lot of detail on Monday at the Finance Committee meeting. But before I came to the meeting, I looked at some of the SER reports, like discharge not final bill. That number does not seem to be going down. Coding delays, that is still a big number. And I guess the question I ask is, I agree with what Greg said. If this is what it is, I'm glad we're knowing where it is, and I think you're on absolutely the right track. But what can we do to fix this faster?
I get asked that question by every single board I do a turnaround strategy with. And unfortunately, there's not a clear answer because we're dealing with governmental payers. So there's a lot of different plays here. The first immediate thing that would tip the dominoes faster is getting us a revenue cycle director. So if y'all are hiding one under a rock, please share it with me. That's all I gotta say. I need somebody boots on the ground, on site, helping me work through the workflows from the minute the patient calls and makes an appointment to the minute that that claim finally gets paid and or written off. Right now, there's 8 different holes in that revenue cycle process. There's 8 unemployed or open roles that have not ever been filled by somebody that's causing us not to get paid right out of the gate. So the first mission is to hire for those roles and responsibilities. The second mission is to shift the focus specifically of QBSS. So every single morning at 6:30 a.m. my time, I meet with QBSS and walk through the claims that I want them to focus on. What has been happening historically is they've been focusing on claims that are easy to work. They're not focusing on the payers that are paying faster and more money. Medicare, Medicaid specifically. We have a high Medicare and Medicaid payer mix. We have seen more cash in the door. You have not seen your DNFB and coding go down because I've not focused their energy and efforts there. I need the payers that I know pay within 21 days back on a 21-day schedule first because that's quick, easy money, and I needed cash to make payroll. From there, once I tip that domino, then I start working into the coding and the patient access denials and medical necessity denials. The DNFB is hung up because our workflows are broken. I've been working with Kyle, and I'm going to butcher names, and I'm sorry. I want to say, I don't think it's Tina. There's another player that's been helping me. I'm sorry. On specifically working on credentialing. We give away so many free services because our providers were not credentialed even. By fixing that, you get paid. So they're working on that piece. So right now we're diagnosing all of the individual areas of opportunity and dividing and conquering and tipping those dominoes. The revenue cycle, for perspective, usually takes 12 to 18 months to flip. So it's a long haul. It's not an easy haul. We have to get the key players in place, and Landon and I are actively searching for a revenue cycle director as part of that process.
So, and just to add on to that, you know, we need to hire a revenue cycle director that has a solid track record. This is a situation where we can't just have someone who is a biller who wants to move into that role. We're not set up to have someone who doesn't have that type of experience. So, you know, the things that I look for in a revenue cycle director is previous critical access hospital experience. That is important. CAW experience. And good supervisory experience. We are actively recruiting. We've had a couple of candidates, none that really have stood out quite yet, but we have been getting applications for that. So hopefully soon we can start the interview process with some.
The other piece to this is also like really important, you had mentioned critical access experience. Our year end is rapidly approaching. We've got a couple days left, which means I get to file a cost report. And one of the things that I like to do that I haven't been able to do yet here is actually file a cost report. A Medicare cost report and a Medicaid cost report dictate your rate per visit. Our cost report last year was sorely missing out on opportunities. By properly booking square footage, admissions by department, true usage of depreciation, allocation of true supply costs, and stepped out allocation of overhead, I can actually move the rate from Medicare and Medicaid to actually being higher if those things are allocated to the right department. And as most department heads know that I've met with recently, stuff is hitting the wrong budgets in the wrong departments. And so we're not getting credit in the right departments that actually get us paid for things. And so by actually working through the cost report process, we will be able to increase our Medicare and Medicaid rates, which will have a substantial bottom line impact for the organization. When I met with QBSS and asked about the rate changes, they didn't even know about them. So that tells you where we're at as far as cost report is concerned.
Now, haven't you also changed the company that will be doing the cost report?
Yes, thank you for bringing that up. I do appreciate that. Yes, the cost report will no longer be with Whipley. And I'm going to tell you, Whipley necessarily didn't do a bad job, per se. It's just there's others that are better. But Whipley also has been doing the best that they can with the information they've been provided. But Brent Wing is actually a sole proprietor and owns his own cost report preparation company. And he's by far the best cost report genius I've ever met. And I don't say those words lightly. I've met a lot of them. I work with a lot of CPA friends on the cost report. But what I like about him is he's going to come on site and measure rooms with me. And we're going to literally square footage this place down to the hallway and the thickness of the walls to make sure that we're allocating things appropriately. And I know it seems cheesy for those of you that don't understand how a cost report works, but by having a 516 square foot room be reallocated to the wrong department could potentially have a $36,000 annual impact. It's that granular. And so it's a glorified tax return, for to put it in the best English way I know how. It's our way of proving to the government we should be getting paid more or less based off the patient population we're caring for. And right now, we've not been taking advantage of that because we are not allocating the square footage and the statistics in the right departments where they need to be.
Brent Wing is who I've used in the past in Ruby Valley. I used him. He's a genius. He's probably the best cost report preparer in the country. He's fabulous. So
Yeah, he's not allowed to retire.
we're going to use him. So.
How often do you do a cost report? Is that an annual thing?
It's formally an annual thing. However, you can use the cost report forecast as a tool, which is what we're doing in the budget process while we're doing the supplemental budget. You can file interims. I wouldn't recommend doing it quarterly, but semi-annually. If anything, we should be calculating it as such so that way we know if we're going to have a liability or a receivable. Right now, we have no idea where we stand, realistically speaking. And once we understand that, we can use it to our advantage. The biggest thing is also, we can't just go cut costs in departments, because by doing so, you actually will hurt your cost report. Certain departments get paid better versus others, because you get 101 cents on the dollar for certain expenses versus others. There's a strategy to it. And that's why having those one-on-ones with the different department leaders is so important, because the department leaders also need to understand if they're a cost report-based entity or if they're not. And if they're excludable, then we get to look at gap funding alternatives and ways to make sure they're functioning from a productivity perspective to keep them going without having a cost report impact. I know that was a long-winded answer, but it's a big story to tell. That's why I actually like the cost report, because it literally can paint a narrative for a hospital pretty quickly.
Any other questions? Hearing none, thank you. I think
Thank you guys for your time.
you've given us a lot to think about, and it's going to be a long and fruitful partnership, I believe. So, going forward, we're looking at Goose Lake Medical Services. A quick report on that.
I don't have much else to add in terms of the financial report. I want to make sure I'm looking at the same report you guys are. Let me pull up this specific profitability. I didn't do anything to this particular financial statement whatsoever, comparative to normal activity from prior. And one of the areas of opportunity, though, I want to make sure we're on the same page of is we'll be working through each of the subsidiary entities to determine true productivity and cost and benefit. I know Whipley, when I met with them this last month, gave feedback on where there's areas of opportunity in each of those entities themselves. So just know we'll be peeling them apart and having conversations. I got to meet Quentin today in the department meeting. We're going to be talking about those types. There's some ways to capitalize on DME. Sorry to call it a name, but I was excited to put a name to a face today. And it's really pulling together those different divisions to be able to increase profitability. But there's no real news to share at this point in time.
Okay, thank you very much, Kelly. Appreciate your reports. Next item on the agenda is approval for Landon to be able to sign on the bank accounts. And this is an annual deal, but Landon's new. He needs to be able to sign checks and obligations for us at WaFd, US Bank, and the State Investment Pool. Are there any questions on that?
So moved that approval be granted for the three WaFd, US Bank, and State Investment Pool for Landon.
I'll second that.
Been moved and seconded to approve Landon Dibdahl on the bank accounts, WaFd, US Bank, and State Investment Pool. All those in favor?
Aye.
Passes unanimously. Mr. Greg Larson, you're up with a geothermal report.
I need that or no? Not a ton to report on in terms of the geo, just mainly because we're kind of waiting on the town council. So they were supposed to meet this week and get back to us. Their meeting got postponed, so we're looking for more information from the town. We're looking for their report from Jacobs Engineering to share with us, which I don't think we've received yet. So, and John, you might correct me on this, but I think the town's meeting next week, right? And then after that, we're gonna have a meeting based on that, and,
Yeah, we sent them a letter to the town that requests two things right now. One is to, I don't know if I need the microphone, but one is to connect the variable speed drive in the geothermal well, so in the summer months, it's not pumping the aquifer, because right now it's just pumping the same winter and summer. And that used to work, but it doesn't anymore, so we asked them to fix that. And the other thing is to clean out or re-drill the well. It caved in, and they found that out this year or last winter when they were doing the descaling. So, and we asked them to get that done by fall. And so we're meeting with, I'm not sure who at the town council, I'm not sure who's running things, but Scott said there would be some council members there to discuss this. But our goal is to get this fixed so it isn't costing us a fortune as we head into the fall months, so.
And the requests from us are based on the analysis from Anderson Engineering.
Yes.
And so we're waiting for their response on that. Yeah.
So we should know more Monday when we have our meeting.
I appreciate your guys' work on this. It is one of those small things that is a financial leak in the district. If we don't get proper heating, it does cost a ton of money, and we are depending on the town, so that's why we're bringing a little pressure there. Okay, thank you, Greg. Quality measures. Alina.
Hello, everyone. My name is Elena Ackland. My name is Elena Ackland, and I'm still, hold it.
It's on. You just have to hold it to your lips.
My name is Elena Ackland,
There
and
you
I'm
go.
Process Improvement and Quality Coordinator here. And we want to present you the key performance quality measure, what we're tracking in the hospital. It's divided by different groups. Most of them are based on CMS requirements. And we will be able to finalize it months ahead, month behind. So it's only April data. Starting this board meeting, I will present it every month. So we're looking on outpatient quality reporting. It's usually a timing matter. With the green lights, you see that when we are way lower than state rate. Red lights, it's a point of improvement. And the yellow lights, it's the point of attention. So we have a set of outpatient quality reporting, then we have a set of electronic quality measures. Every year, CMS increases the amount of quality reporting, what we need to report from the hospital side. And specifically with ESQM measures, this year it's a 6 measure compared to the 3 measures last year. We're standing good. You can go to the next page. Down. Little up. The new measure for this year is a social determinant of health, when we question every time when patient was admitted as inpatient. So we started with a low percentage and going up. It's going to take a time. And a standard measure for acute and emergency department, where we're also standing good. We're working on improving our medication and patient scanning rates. And also the bottom line is a clinic quality measure, which is our Medicaid requirements and impact our quality bonuses.
When we look at the red marks there, what specifically do we do to try to improve in those areas?
Reviewing the patient, some of the red marks is like transfer, go to the first page. Some of the red marks, it's a transfer patients, and because we don't have a high amount of the transfer patient, and this measure is a random samples, it sometimes pull out just one patient,
Okay.
so we can impact on this.
So what about the one at the very bottom that's all red?
The child and the,
This is
What
our
that?
problem. The well child check for kids from 3 to 6, we reach out all the kids to schedule the well child checks. We have huge amount of the patient who cancel or refuse to come. So this is our big problem to set up this measure, and we were losing this for the last 3-4 years.
can we coordinate with the schools at all on that, or is that
It needs to
possible?
be performed in the clinic, as I remember, because it's requirement, it's not just like kids will come and be seen. It's a procedure, like requirements of question, test need to be performed to be qualified as a well child check.
So there have been, like incentive, programs that we tried to do before, I believe. I'm pretty sure Paul talked about that at one point.
Yes.
Right.
I don't think it worked necessarily that well, but trying to get creative to solve some of those, issues is what we're gonna have to do, so.
But it definitely on our point, every provider has outreach list, MA is working to schedule. Also, another problem with this, it's EOCCO measure, and our EOCCO assignment list for the hospital is included with patients who's not living in Lakeview or Lake County. They move out and they don't want to be reassigned from EOCCO.
So
They don't want to lose the insurance, and because it's a huge amount, I mean, I think about 20% of the roster list of the kids what we need to see should be moved out from the list, so they count against us. But we are not in charge of assigning for the Medicaid, and EOCCO can remove them only if patient will call them and say like, oh, remove me from the list, and we don't have this.
Crazy system.
It's a crazy system. And with diabetes, we're also struggling to get lower than 21%. So again, we review the list and catch all the patients who've been seen more than 12 months ago to schedule the new test and check that they're in control. So we have also problem patient refuse to come.
Is that a problem for other districts too?
Yes. I would say that probably there's only 2 major hospitals who can like say that they 100% on all the measures. We're not the last one in Eastern Oregon, but there is definitely a way to improve.
Can you give, like, what's the higher level summary here? Are we good, are we average?
From the
Is this-
hospital side, we stand in really good. With most of the measure, we are lower than state average and lower than national average. So it's a good quality of care. With the clinic, I would say we're in the middle for the Eastern Oregon, because I can see on the Eastern Oregon data.
Okay. Spasiba. Okay, next item is medical staff report. Chief of staff is not here.
I think
wait a
we
minute.
need to go to the HCOPS 2 scores.
Oh, perfect.
This is the scores which calculated every time when we discharge the patient, the vendor, what we paid through one of the grants, send it out the questionnaire CMS approval list. It's a long list and our return rate of respond is about 25%, so only one of the 4 patients responded, which helping us to improve and see what patient.
These are all
Satisfied.
voluntary responses, right?
Yes, it's calculated by the vendor, we're getting only final numbers. So for the last 3 quarters, we don't have a red area, which is good. We were struggling with some patient being disappointed with the, I wouldn't say disappointed probably, was questioning how we're giving the meds, how we describe side effects and what the medication was for, and we bring this problem to the staff, and for the last 3 quarters, we didn't have the bad response on this. So we're reviewing this every month. Also, patient leaving the comments, 95% is positive, and every negative comment we review.
Good.
Okay.
Now it's all.
Okay.
Thank you.
Good job, Elena, thank you.
Yes. Okay, Tori, you're on with the nursing report.
Okay, well, this is, no, it's, don't hold, just let it. I'm not
shout.
gonna do it. I'm not gonna do it. Nursing report is that we are continuing to focus on keeping those HCAP scores up and working with staff on some particular items that need improvement on an individual basis as well as on a departmental basis. Just had our nursing cohort classes finish their term, so we had 2 graduates of the RN program and 2 students who finished their first year of nursing school, and then just learned yesterday that we will have 2 first-year students in our fall cohort, one from Alturas and one from Lakeview, and we will have our second-year students back again, Lauren and Heather, as well as possibly a 3rd student in that cohort from Medford or Klamath. They only have room for one of them at KCC, so we're hoping that one of them will agree to come here and do clinicals here.
Excellent.
Yeah, that's really, unless you have any questions, those are the.
You said there was 2 RNs that just graduated?
Yes, so Ava,
Were you able to hire them full-time?
I'm hoping one will apply to work full-time. The other one, I think, has taken a job in Coos Bay. I know.
Bummer.
Yeah.
Okay. Anything else, Tori?
No.
Okay, thank you very much, appreciate it. Next item, manager reports. Manager, oop, you turned it off, didn't you?
I did, I messed it up completely.
Yeah, oh well. Manager reports, any manager reports at all? Looking at a bunch of negative people, okay. We'll move on then. We'll go to the CEO report. Landon, you're on deck.
Sure.
I don't know,
You gotta hold it for a while.
for a while.
Give it 3 seconds and then it works.
Okay.
Just a quick report, you know, the main priorities that, you know, I'm kind of focused on, number 1 is really what Kelly is focusing on in the revenue cycle, working on that. That's our number 1 priority right now, and that's where we're focusing most of our time and energy. Number 2 is recruitment in terms of both leadership and providers. So we're working on recruiting an HR director. We have an on-site interview with a really solid candidate tomorrow, and we had a video interview with another really solid candidate, actually this week, kind of a late one coming in. And hopefully we'll have them on site here, and it's probably gonna be about 2 weeks. So then hopefully by the end of this month, we'll have made a decision, and can have a candidate be here. They probably wouldn't get here until August, but that's kind of where we're looking at from a time frame there. The CFO search, luckily we have Kelly to help us in the meantime while we conduct that search. I have a couple of firms working on that currently, as well as ourselves just conducting a search, and haven't really had any candidates for that yet, at least none that are in my opinion qualified. And what I'm looking for is someone who is a very, very high quality candidate, because we currently have a very high quality individual working for us right now with Kelly. So she allows us to find that high quality candidate, gives us time to search.
She could come here and work.
I don't know if we could convince her to move to Oregon, but it's a great horse town, Kelly.
I'm in it for the long haul. It just gets to look a little unorthodox with my head on a giant screen. It's fine.
And then, the next piece that I'm prioritizing right now is provider recruitment. So that is kind of a few players working on that. Myself, Stacy, our clinic manager, and Tina in HR, we're all kind of working on that, trying to recruit providers. Haven't had a lot of opportunities there. I do have a couple of ideas, some candidates that have come through our facility as residents that we may be able to work on. One recently came through, another one a couple years ago, and they're in the area. I think they both, their main roles are over in Klamath right now, so maybe we can steal a couple docs from them, so that's the plan. Yeah, those are the high priority areas. That's mainly what we're focusing on right now. Obviously there's a lot of irons in the fire, many things going on, but we're, in my opinion, we're headed in a pretty positive direction. This, obviously some of the things that Kelly talked about, they seem negative, but the reality is we're learning the truth now, and that is a really positive thing, and it allows us to make good sound decisions, and allows you as the board to make good sound decisions. So I really am optimistic in where we're heading. So I think there are good things on the horizon for us. So.
Thank you, Landon. Now we come to the portion, any public comment from our audience at all? No? Yes, ma'am.
I didn't attend meetings for a while because Sam was in the hospital for 62 days. But we used to get a copy of the agenda when we came in. Are we not doing that anymore?
We sure can.
Yeah. We missed that this time. We'll get it to you right away.
Thank you. It helps just follow along and.
You got my copy.
Oh, thanks. You don't need it anymore?
No, you probably don't either, but you
Well, I do for the next meeting we have.
Perfect. Yeah, there you go.
Okay, thank you. We'll try to have those out next time when we meet.
Thank you.
You're welcome. Okay, what we're going to do now is adjourn into executive session under ORS 192-660, bracketed 2, bracketed A personnel, and bracketed E real estate. I will take a 5-minute break.
Recording.